Welcome to Board Certified, expert interview episodes about medical licensing exams and healthcare careers. I'm Tyler York, CEO at Achievable, here with Cassandra, who on the marketing team, and Achievable offers affordable online adaptive prep courses for the USMLE Step 1, MCAT, PTCE, NPTE, and others. Each of these courses contains everything you need to succeed on the exam, including comprehensive study guides, video lessons, thousands of practice questions powered by our spaced repetition algorithm, and full-length practice exams. You can try any course for free at achievable.me and use the code podcast to save 10%. Now, let's get started. Today, we've got a special guest, Nicholas Volpe from Northwestern Medicine with us. And Nicholas, I'd love if you could introduce yourself.
Sure. Good afternoon, Tyler and Cassandra. Thanks for having me. As mentioned, my name is Nicholas Volpe. I am the current chair of the Department of Ophthalmology at Northwestern Medicine, which is the Feinberg School of Medicine here in Chicago. I've been the chair here for the past 15 years, and I've also most recently been the president of the Association of University Professors of Ophthalmology, which is the national group that organizes academic ophthalmology programs. I've had a long career advising medical students on their journey to ophthalmology residency, and of course, training ophthalmology residents both here and at the University of Pennsylvania. And I had done my residency at the Massachusetts Eye and Ear Infirmary and the Harvard Medical School Ophthalmology program.
Great. Yeah, thank you so much. And Cassandra and I will both be kind of giving you questions today. I think I'll start out by just talking to you about just the competitiveness of the ophthalmology residency and in general, just kind of the popularity of the field. Can
Sure.
you speak to that a little bit?
Absolutely. Ophthalmology has, for a very long time, been, for better or worse, one of the more competitive residencies for medical students to apply to and to be successfully accepted into. That reflects a relatively small number of training spots and a fairly large interest on the part of students. It's obviously a wonderful field, and I'd be conflicted if I didn't tell you that it is a fantastic practice to be an ophthalmologist and to be able to restore vision and take care of people with different eye problems. That being said, the statistics are in the applicant's favor. If you look at the most recent match data, somewhere between 85 and 90% of U.S. medical school seniors applying for the first time will successfully match into an ophthalmology program in this country. And probably somewhere between 60 and 70% of them will get one of their top 3 or 4 choices. So it's not prohibitive, but because it is competitive, the sooner you start to think about it and begin to prepare yourself as an applicant might afford you some advantages.
Mm-hmm.
Traditionally, there are, a few specialties that each have a different path, if you will, about how you get to the more competitive residency. Some of them only pick people they know and have audition. Some of them have different paths for how to be selected into them. For ophthalmology, there's a formula, if you will, on one hand. On the other hand, and I'm sure we'll talk about this at length in the next few minutes, it's really about presenting your authentic self and really trying to distinguish yourself from other very qualified people. That's the name of all games of application. As we have switched to a pass-fail system for the USMLE 1, that has sort of eliminated a sorting hat, if you will, because in the past there were certain barriers to entry that most medical students knew about that basically put you at a disadvantage. Not that only people with high board scores could get in, but there were many places that often chose a board score, if you will, as a threshold to sort of start screening applicants. Just to give you an idea of the scope of why screening and how you present yourself as an applicant is so important, we have 4 residency slots a year here at Northwestern. And I think most recent total is that we got about 650 applications from around the country.
Wow.
Now, that sounds like a lot, but those 650 applicants are applying for more than 500 spots across the country. So it's really a question of sorting, and that sorting becomes difficult based on how applicants present themselves and how people read applications. And more competitive programs in the past would rely heavily on board scores. We have other methods now of sort of sorting through these applications. We use a kind of holistic approach, which we can certainly get into during the discussion. But in general, it's about presenting yourself as a unique applicant, and particularly being strong at the school you're in or you're attending, so that you can have ophthalmologists at your school advocating for you and or taking you into their program and or connecting you with other programs around the country. The traditionally competitive residencies like orthopedics and dermatology, they all have that same quality where you can't just wonder whether you're going to get a good residency or a great residency. You have to wonder whether you're going to get a residency, and with that are often in a position that you're going to start thinking in your first and second year about what to do to distinguish yourself from other applicants, while at the same time recognizing that this is a bunch of super smart people who have achieved a lot just to get to this point, and you have to be careful about overdoing it, if you will, when you apply.
Mm-hmm.
Yeah, that feels like such a a balance that you have to kind of figure out. And you talk about having a unique application. Do you have any examples of like what that might be? Obviously, it's going to differ by each individual, but maybe like any examples of things you've seen that really stood out that was like, yeah, they're a fit.
I think you can fit that into a number of different categories. And in the end, as I alluded to earlier, it's really about presenting yourself and your strengths in the best possible light, just to know that you have achieved. And generally, we're looking for people that have distinguished themselves in something. It doesn't always have to be research or in college or the kind of college they went to. It just means that if they picked a few things that they were interested in, that they've risen through leadership roles, that they have succeeded in a business or written a paper. We're looking really for people that have done a few different things and been able to excel in at least some of them and rise to the point where where they have leadership roles and or have had a significant presence or presentations or other evidence that they have kind of risen to the top of that group. I think that's a very important distinction from, the folklore that's probably out there about, you have to check all these boxes. You have to have done research. You have to have volunteered. You have to have, been on a rotation with some famous ophthalmologist. You have to love vision science. There's a million different ways that students read about all these different things, and then you get an application where there's 20 things started, and nothing ever gets past a poster, an abstract, and all the only evidence is that they saw the website that suggested that the more of these things you do, the more competitive applicant you are. So some people who come from different backgrounds have taken different pathways. They have started a business. They were the leader of a nonprofit. They were an engineer that had a whole other career before they did it. They've done something to distinguish themselves. There are some obvious ones that appear, and those are people that, for instance, have done a PhD during medical school, an MD PhD student who's done vision research and has really committed to a career as an ophthalmologist interested in vision science. That's one version of an outlier. Then there are some outliers that have gotten to a point in life because they do have an impressive pedigree in terms of where they were undergrads and where they went to medical school. But in the end, there's always a way, again, if you're really good at what you do, to sort of take it to a level where not only did you volunteer with the ophthalmology interest group at a community health clinic, but you ran the program, you succeeded in getting 20 more students to join. You were the first student to have 1,000 patients examined in a 6-month period. You just pick things that, as anyone knows from their career, that if you're going to do a little bit of extra, you'll be able to distinguish yourself. None of these things, of course, mean that you're going to be a great ophthalmologist. It just means that because we're a competitive residency, have the right to try to pick amongst the best students and try to match them into a residency. But as I said, it's more of a sorting hat thing, because in the end, 80 or 90% are going to match. But do they match at Northwestern, or do they match at Michigan, or do they match at Iowa, or do they match at UIC? We have the application process and then interviews. It's a somewhat arduous series of events that leads to this matching program. Like every other residency is a matching program, right? So it's not like college or med school where you get 5 or 6 acceptances and you have to pick one. You have to actually pick some place to match. And each of us have different kinds of things that we think are important. I think letters are really important. Each applicant has 3 or 4 letters to ophthalmology residency, and the more those letters sort of indicate one of the best students I've ever worked with, a true outlier, as opposed to, future Dr. Wheeler was always on time. She had a pleasant personality. Patients liked her. She worked well with the staff. I think she'll turn out to be a very good ophthalmologist, something that, means that you did all those things, but you didn't, say this is a really different kind of medical student. And, either you have that or you don't. And, quite frankly, when we assess students that may or may not have that, we sometimes encourage them to apply to other fields also, just in case, to have a backup and or, take a year and do research, which I'm kind of a little bit ambivalent about. I don't think you should do that, quote, research year, again, just to check a box and have something else you can put on your application. But if you're passionate about research and you think you can excel at it and have an impressive run, get a good letter out of it, then taking a year out to do research might be a reasonable thing. We do have a fair amount of students that do these audition electives. So this time of year is very busy between August and October, where students from other medical schools that either want to be at Northwestern, want to be in Chicago, their school doesn't have a big ophthalmology program, whatever, they apply to do electives within our program for a month or so. They have a chance to sort of check us out, if you will, but they're also, everybody realizes that they're auditioning or so, or just trying to get known as a person as they come. And those particular audition electives have become a little bit more important because we've switched to all virtual interviews. So as much as we'd love to bring people here because we have a beautiful campus and a great home court advantage, we no longer have that opportunity. We have to meet them like this on a screen, and they don't get to see our fancy place, and we don't really get to see them interacting over lunch with our residents to see if they sort of pass the is this person normal test. That is probably the most important, right? The more you can present yourself as a high EQ team player who's also really smart and passionate about being a doctor, the more likely you are to be accepted. But none of these methods have ever been proven to be superior. It's not like, because if there was one formula that made you a great applicant or more likely to be picked by both Michigan and Northwestern, then we just plug it into ChatGPT and we'd all get the best applicant, but then it would give the same answer. And in the end, some of the people we thought were going to be great are great, and some of the people we thought would be whatever turn out to be the best residents. So it's an unfortunate process, this matching process, but it's the best one we have. And certainly moving forward, I think as the specialty continues to stay popular, as I suspect it will, we're always looking to refine it in ways that make it better in terms of an application process.
Yeah. I'm curious too, is there, how much weight it goes into, networking and mentorship that kind of influences matching into some of these programs?
Yeah, I think like as it is in every other part of life, there's a who you know component of it. And if someone that I know wrote a letter for somebody who was, for instance, a Penn medical student where I used to be on the faculty, then that letter is going to be a little bit more meaningful. It'd be even more meaningful if someone texted me on my phone, "Hey, I just wrote a letter for Cassandra. I think she's a really great student. Please take a careful look at her." And hopefully at that point, you realize that they're truly advocating for the student as opposed to, thinking that they're a little weak and they need a little help. But there is a fair amount of that. It's not quite as I imagine the business or the real world is, where there is a lot of, kind of the who and networking and a chance to really display yourself as a high EQ person, which is equally important for doctors as it is in people in non-healthcare industries. But there's still this other big piece of it that you have to get through, and all the networking in the world isn't going to get you past a mediocre application. So there's a little bit of the who you know. I can tell you that it's usually, the way it usually shakes out. If you picked a number like 600, there are probably, it's not hard for us to go from 600 to 200, in terms of applicants we might be interested in, and we end up interviewing 50. So that 200 to 50 is probably the hardest transition that we have to go through, because everyone's good on paper. There we start to get into who do we think really wants to come here. So that, I think, is there's a new feature now in ophthalmology residency, which is the second year we're doing it, where applicants can preference signal 10 different programs. So unfortunately, for better or worse, we've decided that we're not going to limit the number of applications. And despite the fact set that would tell an applicant that they are no more likely to match with 50 applications than 40, right? So after 40 or 45, your likelihood to match does not go up. But at whatever it is per application, it's a Visa card moment, if you will. And people are like, well, you never know if that 68th program I applied to is the one that I interview at, and I wouldn't have been. There are obviously exceptions to this. Most people don't do any better after 45 applications rule. And the way we've sort of dealt with that is to add this preference signaling, which, is a double-edged sword for the applicant, because in some sense, someone who needs to be in Chicago can list all 6 Chicago programs as preference signaling. They can make that very clear that they're Chicago bound because that's where their partner is, or that's where they're from, or that's where they want to be. And it allows us to kind of get through that 600 and look at the 100, if you will, that signaled us, and take them a little bit more seriously. Frankly, I would be much happier matching my 15th choice of resident who wanted me as their first choice than my 14th choice who wanted me as their 10th choice, right? The match is best when both the applicant and the program are equally excited. And depending on how good or competitive you think your residency is, then there is an advantage to picking the right people to interview, right? It doesn't, because we only interviewed 50, it doesn't mean we interviewed 50 students who all went to Harvard and Stanford and whatever you consider the best medical students. We interview the 50 people that we think are the best people who really want to be here, who will fit in here well, who match our culture, and all those other things. But the preference signaling allows that 50 or 60 application person to pick 10 or so that they're most interested in. And there's probably a whole bunch of game theory out there on the internet about, do you pick hard programs? Do you pick easy programs? Do you pick safe? There's no such thing as a safe program. If some person reads the application and doesn't like you, then no matter what you did or signaled or something you wrote in a personal statement, then no signal is going to matter. But the signaling has sort of helped us to understand who, for whatever reason, has taken enough interest to say, if I only had 10 places that I could be, you'd be one of the 10. So that has been very well received, and is pretty popular in most of the other specialties now to have this preference signal.
Great.
Yeah. Oh, sorry, Tyler.
No, go ahead, Cassandra. Yeah.
Yeah, I'm just curious, what should students know about, the maybe intensity or lifestyle that could be different with other specialties? And, are there any differences? Obviously, different studies and research go into that. But what is the expectation for, that students should be aware of going into this specialty?
The kinds of things that make you a successful ophthalmology resident, as opposed, like, assuming you've gotten in, or
Right.
how you display yourself on your application. I think we talked a lot about the second one, right? You basically want to, present yourself as someone who's either excelled in science or socially or academically, or specifically in research, or something that really shows that you're an outlier in one of those areas, or that, equally importantly, that you've chosen a unique pathway, or that something about your pathway really indicates a great deal of hardship that you overcame and a great deal of grit that always appeals to people, just to know that they've been willing to sacrifice and work harder than maybe any other person would because of the pathway they're on. There's no doubt that we are much more likely to accept people that we know in some format, either our own students or students that have done electives with us. And again, when there's 150 or 200 people that kind of all look the same, the person who worked with you in clinic, who seems nice, they're from Chicago, they want to be here, those things obviously are an advantage for somebody who's a Northwestern student, but a disadvantage for somebody who's in Cornell or someplace in New York City where we don't know them. But if they come here, boy, that signals to me that they were interested enough to spend a month here checking out our program. I'd like to think that we're pretty good at predicting who will thrive in ophthalmology residency. The ophthalmology residency is, for better or worse, probably not as rigorous as, a transplant surgery residency or an OBGYN residency. It's just less brutal hours and less emergencies. But our residency is certainly pretty tough in terms of call and responsibilities for the first couple of years. Your first year, you're basically an intern, just like everybody else in the hospital. You do surgery and medicine and emergency room, and you're as busy as any surgical resident would be doing different rotations. In the second year, you have a big responsibility for covering call, and as a downtown urban medical center, we obviously see lots of emergencies and trauma and sudden vision loss, and that's a very, very busy experience. So those things are the same, but our residents, for instance, are not sleeping in the hospital. They're not running to people that are bleeding to death or other things like that. So it is, in that sense, a little less intense, but there's no less amount of work per se. And then as we move through the residency, and then there are more people to cover call, and you're doing backup call, and you're only doing surgery, then it gets significantly more refined, if you will, in those 2 years. But during the day, it's as hard a grind as any. One of the interesting things, whatever, about ophthalmology residency is you do as a resident what you'll do for the rest of your life. When you're, for instance, a pediatrics resident, you take care of sick children in a hospital that have these crazy exotic diseases. You don't do well baby care and vaccines and other things that happen in outpatient pediatrics. So ophthalmology residents do care and surgery much like they will do for the rest of their lives, and therefore can have experiences that help them pick their subspecialty that are very similar to what it will be like when they're an attending and have completed residency. I think the things that make residents most successful are the ability to always put patients first, and to be able to know that the harder decision to do something or to see a patient or to take it to the next step is always the right decision, as opposed to the easier decision, which may be to let some things go or to come in a little bit later, or things that don't reflect probably the best interests of the patient at that point.
Yeah, that's really interesting. And then I'm just curious, for a student who maybe isn't quite sure about ophthalmology, maybe they're a little curious, what's kind of like a good first step to start exploring that field and see if it's maybe a right fit for them?
Yeah, I think that's a great question. No matter what you come to medical school with, I always encourage people to start with a clean slate as they consider specialties. You don't want to do your whole med school knowing that you're going to be an ophthalmologist and sort of disengage or tune out of the things that you decide are not important. So I think it's most important that you spend the first year and a half or so just learning the basics of being a doctor and the basic sciences of medicine. During those first couple of years, and every medical school is different, but our students have opportunities to shadow with different specialties, to be part of interest groups. We have a summer, and our first year summer is dedicated to an area of scholarly concentration where the students do a research project. You can pick a research project that's ophthalmology, but I don't think you can really make a decision until you get going in your third year and you say, these are the things I like, these are the things I don't like, this is what appeals to me about surgery and or anesthesia or OB or radiology. These are the things that appeal to me about ophthalmology. No field is perfect. I don't personally believe that there's only one specialty for a medical student to pick. There's probably a lot of things they could be happy doing. They just have to decide that, it's a 30, God willing, 35-year career, that you have to be passionate about it. You have to bring an interest in. There's nothing more important to me than vision. And if I can save people's vision, I want to be able to do it. I love doing microsurgery. I love doing public health issues. I love doing international care. There's tons of curable blindness around the world. And quite frankly, 5 miles from where I sit here in Chicago, where people have health equity issues that are very important. But at the same time, you're using it's a very technology-driven field. Some of the greatest therapeutic advances have been made in ophthalmology. We're the first and only specialty to do gene therapy for diseases where we're actually inserting new genes in people's retinas. We have great technologies that allow us to image the eye, but we see a lot of patients, right? If your brain is not geared up to seeing 40, 50, 60 patients a day, 2 or 3 days a week, and operating 1 day a week and kind of moving at a high pace, then it's not great for you, ophthalmology. If you're really into being in the hospital and being with the other doctors taking care of inpatients, then ophthalmology may not be right for you, since it's a very outpatient specialty these days, except at a place like this where we're at a medical center with patients with lots of unusual and complicated disorders. But you should know it. You should, in those first couple of years, you should shadow a lot. You should go to conferences. You should read. You should find out what kind of things. And I think it's pretty easy to rule things out that you don't want to do. The things that just are different enough that, like, there's no way I want to be a neurosurgeon or a gynecologist, but I could see doing ophthalmology or ENT or cardiology or some things that have procedures and they're outpatient and they have a vital organ or whatever it is that might be important to you. And then once you get those 3 or 4, then you got to really look at what's the nuts and bolts of doing it. And in some ways, I like to advise students to actually pick the one that has the most palatable bad thing about it that you have to do a lot, right? So, like if you're an ophthalmologist, as I alluded to, you have to be used to seeing a lot of patients, moving through them quickly. You're not going to be able to spend an hour with every patient telling them the story of their life or their disease. You have to, recognize a pattern, make a decision, and move through that. Some people are just not comfortable with that version of it, and they'd rather, have more inpatients or be in the operating room for longer cases or things along those lines. So you have to pick what is the grind of that specialty and say, I like that grind. That makes me happy to see Mr. York 3 times a year for his glaucoma, check his pressure, let him know it's great, that he doesn't need a laser this time, that his visual fields are perfectly stable, that his optic nerves are showing no signs of any cell death. And, I made Mr. York's day, but I also at the same time, used my brains and my technology to make an assessment to know that his glaucoma was not making him worse or more likely to make him blind. So that's a very personal journey. And I think, there are obviously practical considerations that some medical students take into consideration as they pick a specialty in terms of lifestyle and income and where you can live and who you want to take care of. And those are very real issues that are practical, but there's nobody listening to this podcast who's going to do a residency in anything that isn't going to be in the most wonderful profession that is completely respected by the public, where you can have a job wherever you are, that you're going to have a chance to help people, that you're going to have a chance to educate and participate in collecting new knowledge if you want. You have to go into this as a medical student, realizing how lucky and privileged you are to have gotten to this point, and take the gifts and the strengths that you have and be able to help people and to change their lives, whether it's as a brain surgeon, a psychiatrist, an ophthalmologist, an anesthesiologist, whatever you do, you have your role. We have an incredible system of care here in this country, at least for those that have equal access to it, and a chance to participate in that, has to be viewed not as a job, but as a real gift and an honor to be able to do it. When you feel that in a specialty, I think that's when you're most likely to be happy.
Yeah, I think that's, a great way to sum that up. And it's, such a challenging journey to get there, but, probably one of the most, if not the most rewarding, career paths. But I wanted to kind of jump back a bit because you had mentioned like technology advancements and kind of how that plays out. And, I feel like I have to bring it up in the age of AI and if that, comes into play at all in this field. And, kind of what have you seen, in your experience for all of these technological advances and how are they kind of moving the needle forward?
Sure. I mean, again, this is I'll switch to a propaganda for ophthalmology piece here, but there is no field that has there's no field in medicine that has more potential impact for AI facilitated both research and care of patients. A lot of that is because one of the most beautiful and wonderful things about our field is that we can almost always see and take a picture of our diseases, right? So when we shine a light into your eye and look through your pupil, we can see your optic nerve, we can see your retina, we can see microscopic blood vessels. This is with the naked eye. We can then take a picture of that, a photograph, in which glaucoma, cataracts, diabetic retinopathy, hypertensive retinopathy, tumors would all show up on a photograph just like they would show up on our exam. Now we have technologies which show microscopic blood vessels in your eye that I couldn't see, but that a computer who's analyzing those pictures can determine, whether you're more likely to have diabetic retinopathy, whether your glaucoma is likely to progress, maybe how long you're likely to live, maybe whether you're going to get Alzheimer's disease, maybe, based on our, feeding this information in, this is a patient who is very likely to develop macular degeneration, and therefore you should be doing these 3 things to participate in their care. So because we have millions and millions of images that we've taken over the past 25 years, digital images of these pictures to follow patients, there are many, many companies that are taking all these images, analyzing them, feeding into machine learning environments where machines are making better decisions or more informed decisions than we can make as human beings that are really facilitating the care of patients. We're at the point where our engineering colleagues can make sort of a model of your eye and use augmented intelligence to be able to predict how to do the best glaucoma operation for Cassandra's eye versus Tyler's eye and which one will work better. So this is going to really change what we do. I think it has some chance of replacing what we do as ophthalmologists, since we can take a picture of everything. So why go to the doctor if a few years from now you can hold your phone up, take a picture of the back of your eye, feed it into some machine. They said, no, you're good for 5 years. You don't have diabetes, you don't have macular degeneration. Here's your prescription. Those things are all going to be possible, certainly in our lifetimes moving forward. I think it's decades before machines are doing surgery and machines are doing injections in people's eyes and things that are just going to require the human touch. But we are all very actively trying to determine what are the best ways for these databases that we have to be able to inform personalized and precision medicine, because we now have stuff where we can look back to what it looked like 15 or 20 years ago. We know what it looks like today, and then have this super smart being that we call AI kind of sort it out and be able to predict, well, based on how this patient did over the last 20 years, someone you're seeing today, we can predict what's going to happen to them over the next 20 years, not only to their eye, but to their body. You can measure congestive heart failure looking at retinal blood vessels, and it's a little less relevant to eyes and vision, but it shows how important the eye as an organ is, as it windows the disease in your body. There's no other organ where you can actually see the diseases and see the blood vessels that are affected by disease, because obviously if you can see, then I can see, and that's very informed. By the same token, as I mentioned with Alzheimer's, the retina, the part of the eyeball that you receive vision through, is a card-carrying member of the brain. It's full of hundreds of different types of neurons. How those neurons communicate with each other will help us understand how the brain works, how they degenerate in different conditions will help us understand how some of our most dreadful degenerative neurologic diseases like Alzheimer's and Parkinson's, how they may be affecting neurons and whether we'll be able to detect them and therefore know people need treatment or determine if treatments are working. Those are all things that technology will inform. So it's truly a wonderful time to be part of that story, and the collaboration we have now between academics and ophthalmologists and industry that's obviously very interested in creating these cameras and these devices that help us to assess patients is just at the very beginning of a transformative generation.
Yeah, that's so interesting to me. And yeah, like you said, what a time to be, in the midst of this. But great. Is there anything else that you wanted to make sure we cover?
No, again, I think it's very easy for me to sit in my perch and tell people, don't worry about it, just be the best person you can be. And I'm the parent of two recent medical students that are in residencies now, neither in ophthalmology. And I know what it's like to go through that decision making and to have to deal with the anxieties that go into that and being able to control things. But in the end, in a matter of a year and a half, you can't change a 23 to 29 year history of accomplishments and performance and other things that have indicated all of your individual greatness, right? So I would urge people not to obsess on checking 8 or 9 more boxes, but to have relationships with mentors that they admire so that they know that, boy, if I could be like this person or this person really inspires me, that I'll have a great career, getting to know people that could then write great letters for you, that there's nothing about this that's volume. There's no difference between someone who wrote 3 papers and somebody who wrote 6 papers. The 6-paper person is not more likely to be accepted. It's more the person who really understands the research they did, has the collaborator, the mentor that they did the research with saying, I've never worked with a student like this before. This is a guaranteed outstanding or superior resident. So being able to just take the things that you're passionate about, because when you're passionate about it, then you don't mind spending hours doing it, excel at that, and then present yourself in the most favorable way in your application. Spending a lot of time on how you put that application together, how you write your personal statement, how you put your letter writers together, and again, recognizing that you shouldn't try to change a record of accomplishments that has existed for 25 years. And being able to talk about that, having the eloquence and the EQ to promote yourself without being overly obsequious or overly indulgent in terms of your accomplishments. Nobody likes chest pounders. Nobody likes applicants that have sort of identified themselves because of X, Y, or Z as being outstanding. That people can see through that almost immediately, and that never makes for a good resident. They'll eventually, people like that, if they're sheerly brilliant, will excel and become outliers, but there may not be people that you'd want in your residency program. So that's another thing where you have to be careful about how you present yourself, and doing that on an interview like this is tricky, right? If you're meeting someone, you get 15 minutes with 3 different groups of 3 people that are asking you questions. Tell me about yourself. What's your favorite hobby? What else do you like to do? Those kind of things. There are people, who have the gifts that can really tell their story, and you may have a great story, but not such a great application on paper. You got to have the great application on paper to be able to tell your story. So those kind of things sort of play off each other. And in the end, the sorting hat that is the matching program, ends people in different places. And there are 120 or so different ophthalmology residencies around the country. Probably 100 of them are great or good enough or wonderful places to train that, don't have any problem making great ophthalmologists on one hand. On the other hand, the place you pick for your residency will ultimately help you differentiate into something. again, not one right answer, but some version of yourself where that particular residency helped you to realize what you wanted to be when you were finally grown up.
Yeah, fantastic. Well, thank you so much. This has been Board Certified, hosted by Tyler and Cassandra from Achievable with Nicholas Volpe. And Achievable has great online courses for the USMLE Step 1, MCAT, PTCE, MPTE, CSCS, and others. You can try them out for free at achievable.me.